I am talking today about the role of high-dose rate brachytherapy in cervical cancer. So we're going to switch gears a little bit. We've heard a lot about epidemiology and screening, and we'll talk a little bit about the treatment of cervical cancer. So we'll go over the treatment of cervical cancer by stage, review the evidence supporting the use of brachytherapy, description of what high-dose brachytherapy is. I'll show some pictures and describe the various applicators that we use, and briefly go over the techniques. I know we're down to a short amount of time before lunch, so thanks for bearing with me. So we've seen this, this map of the worldwide incidence of cervical cancer from Globocan, so I won't expand on it, but obviously the 30.2 per 100,000 people is quite impressive in sub-Saharan Africa, Tanzania included, and then sure enough, with such a impressively high mortality rate in this region as well. So often those of us in the US get so we feel bogged down by busy clinics and treating so many patients, but when you look at a map like this, it's really humbling. So it's wonderful that I am going after the talk about what screening tools are available here in Tanzania. So as a quick reminder to us all, and to put everything in perspective, what is the percentage reduction in mortality that's been able to be achieved in the US with PAP screening program? And the answer is 70%. And so those of us in oncology celebrate overall survival improvements of 10%, and it's practice changing. But when you look at numbers like this, it's really remarkable. So we'll hope that the screening program that's starting to be developed in KCMC has the same outcome. So we'll go through treatment strategies by stage. Here, these are the early stage 1A1s, 1A2s. This is according to FIGO Staging. And I'll just highlight for you the role that brachytherapy may have in each of these stages. 1A1s being microscopically detected lesions confined to the cervix that are smaller than 3 millimeters in depth. And certainly conization is an effective treatment. So can be an extrafascial hysterectomy. And then brachytherapy alone actually has had some success in the US, especially with those patients that are unable to undergo operative therapy. And then if lymphovascular space invasion is seen at the time of conization, many of those patients go on to receive external beam as well as brachytherapy. For the larger tumors, 1A2s, hysterectomy versus external beam and brachytherapy are the recommendation. So as you get into the higher stages, 1B1 and so 1Bs and 2As are broken down into whether or not the tumor is less than 4 or greater than 4. The non-bulky 1B1s and 2A1s, those patients are eligible for hysterectomy and pelvic lymph node dissection, and then for higher risk features seen under the microscope, we often give post-op chemo and radiation, but certainly as definitive therapy, pelvic RT with brachytherapy and concurrent cisplatin is the recommendation. And then the more bulky lesions, 1B2s and 2A2s, the recommendation is for pelvic radiation with brachytherapy along with cisplatin-based chemotherapy. And the reason for that is those patients have such a high risk of requiring adjuvant therapy that we often try to spare them the risk of the tri-modality therapy. So as you get into the more advanced stages, the 3As with distal vaginal involvement, and then I can just talk loud, that's okay. So the 3As with distal vaginal involvement and the 3Bs, parametrial involvement or pelvic sidewall involvement. Many of those patients are detected on ultrasound actually when they present with hydronephrosis. And then for the stage 4As where there's bladder or rectal involvement, the recommendation is for pelvic RT with brachytherapy and cisplatin-based. Oh, thank you. Cisplatin-based chemo. So, pretty much in every single stage, there's an important role for brachytherapy. It's working. Okay. All right. So, as we can see, this is one of the sites where internal radiation, in addition to external radiation, has a very important role in the curative treatment of brachytherapy. What I haven't talked about is the role in in palliating these tumors, and I believe there's a talk this afternoon discussing the palliative care options for brachytherapy. So I won't go into that, but that is a point that I'd like to mention, that brachytherapy can certainly have a role in treating local pelvic masses, even if the intent is not for cure, but perhaps it can be used as a way to avoid surgery, chemo. In the absence of pelvic radiotherapy, it's a decent option. So what is brachytherapy? It means nearby therapy. It is our solution to placing radiation dose directly next to the tumor. And high dose rate is when we use an intense source of radiation. Usually this is iridium-192, and this is delivered through temporally placed applicators in the patient. So the wonderful thing about brachytherapy is you place these applicators and then the entire apparatus moves with the patient. So you do not necessarily have to account so much for patient movement. You tailor your applicator size and location based on the patient's anatomy. As the dose runs through the catheters, it's delivering its highest dose in the center of the tumor. And we believe that what this creates is a very, very hot dose right next to the applicator and a very quick dose fall off. So you're not having to go through the nearby normal structures, bladder, bowel, rectum, in order to reach the tumor. And so if you can control how much dose you're delivering, and also you're very aware of where the dose is going using high quality planning techniques, you can really limit the toxicities with this treatment. So what I have on the screen, these are CAT scan images. On the upper left is a coronal view. On the bottom left, that's an axial view of a patient who has a brachytherapy implant in, and those various colored lines are isodose lines. They represent where certain doses of radiation are going. The lines closer to the center are higher doses, and you can see the dose is very hot right next to the applicator, and then it very quickly falls off. On the right is same CAT scan, so coronal view, axial view. And what this is it's an attempt using external radiation to deliver the same high dose right to the tumor. But what it's displaying is that when you're using external radiation, you're having to go through several normal tissues. And so what you end up with is a low dose spread out through your normal tissues. And so the reason HDR has been, or brachytherapy in general, has been around for so long is because we like to take advantage of the fact that you're delivering dose right to the tumor, and you're really doing a very good job of sparing the normal structures. So does brachytherapy increase local survival and local control? And the answer is yes. We know that looking back when we're able to dose escalate using brachytherapy, the local control numbers, when you look at doses delivered less than 80 gray versus those that were delivered to 80 gray or above, the local control is drastically improved. So the tumor control probability does correlate with the radiation dose that you're able to deliver to the patient. There have been several studies that have shown this, but this is an example where if you're looking at external radiation alone versus external radiation plus brachytherapy, there's not only improvement in local control, but also in 4-year survival. So talk in detail about HDR brachytherapy and the pieces, the apparatus involved. So what we have here, this is the housing unit for the iridium source. And that source is attached to the end of a wire, and the wire drives the source along catheters into applicators that have been placed in the patient. And that source dwells into pre-planned position for a preset time before stopping at various locations along the catheter. So the radiation oncologist is in charge of determining the position and the dwell time. And so by varying the position of the source and how much time it spends in each dwell position, you can tailor your dose around a target. So here's an example of various applicators. There's a tandem ring and tandem ovoid, and that the tandem is the name of the central piece that goes into, it goes through the cervix and it sits inside the uterus, and then that ring is sitting right up against the external os. tandem and ovoid, you have the same tandem, but instead of the ring, you have two side pieces called ovoids, which are sitting right up in the vaginal fornices, again, right next to the external os. Occasionally, we'll also use a tandem and cylinder. This is for patients that have limited disease along the length of the vagina, but their disease does not penetrate deeply through the vaginal mucosa. So it's really limited and not widely used, but it can be helpful for those patients that present in this way. It has a very narrow distribution. You will not be able to reach tumor that is involving the vaginal fornices or tumor that extends beyond 5 millimeters from the surface. And then for bulky disease or patients that have distal involvement or disease that is greater than 0.5 cm, we'll use an interstitial implant. So I'm always talking about HDR. I use HDR in my clinic. The general trend in the US has been to convert from low dose rate to high dose rate for a variety of reasons. And in the interest of time, I haven't gone into depth, but basically our American Brachytherapy Society has come out with consensus recommendations and a statement from their 2012 consensus recommendations is as follows: HDR and LDR seem to be relatively equivalent in terms of survival outcomes based on existing retrospective and prospective analyses. The point is there is not a great head-to-head comparison in a prospectively done trial, so we don't really know the answer, but for the purposes of less exposure risk to patients, getting all the procedures done in an outpatient setting, allowing the radiation oncologist to use a computerized optimization of dwell positions and some of us think come up with a better dose distribution. We can adjust treatment over 5 fractions instead of just 1 to 2. And I think that really is a good point because you see these tumors shrink quite a bit through external radiation. And instead of delivering all your dose in 1 to 2 fractions, you're able to really tailor the dose according to how the patient has responded. So we won't go into too much detail about this, but there is a conversion needed when you go from low dose rate to high dose rate, and it has to do with something called biologically effective dose, which is our way of standardizing how radiation therapy interacts with human tissue. We also use something called equivalent dose in 2 gray fractions. Most of what we know about how radiation interacts with the body is based on external radiation delivered at 1.8 to 2 gray per day. So in an effort to standardize our language in terms of prescribing dose and understanding toxicities, we use these 2 concepts of biologically effective dose, or equivalent dose, and equivalent dose in 2 gray per fractions, or the EQD2. And it's important to calculate the total dose that the patient's receiving. Most of these patients are being treated with external beam first, followed by a brachytherapy boost. And so you'll have to add the 2 together using the EQD2 calculations. And so we'll stop there with the technical talk. Commonly used HDR doses: 6 gray times 5, 7 gray times 4, 8 gray times 3 are all relatively common. Probably the most is that top one, 6 gray times 5. But in this era of, as we've converted from 2-dimensional to 3-dimensional planning, especially with the aid of MRI, some of us, in patients that are also getting sensitizing chemo, have actually lowered that dose. So 5.5 times 5 is actually quite common. If you go back to that prior slide, I gave the example of 5 fractions times 5.5 gray. The EQD2, 35.5 gray. So I'll briefly describe the brachytherapy implant. This always begins with a clinical exam. Exam under anesthesia is standard. However, it's always done before patients start therapy. It is not always done right before the implant. So at the very least, a clinical exam is done. At best, exam under anesthesia. The applicator is chosen based on the extent of disease. A Foley catheter is placed. And our standard balloon size is 7 cc's, and that has played a role in defining our 2-dimensional points that we are supposed to pay attention to and report. And so many of us still follow this convention of 7 cc's in the Foley balloon. We place markers in the cervix at the time of the implant, which will help you when you're looking at your either x-rays or CT for planning. The cervical os is dilated, and then under ultrasound guidance, the uterus is sounded. The tandem, the central piece, is placed inside the uterine cavity. There's something called the flange, which is this piece right here. And that sits right up against the external cervical os. The largest size ovoids are chosen, and that's the larger the size, you will reduce the dose to the vaginal mucosa. The ovoids are placed into the vagina to their maximum depth, and then they are expanded so that there's approximately 3 to 4 cm separation in between. And then the whole apparatus is tightened down, and the apparatus is packed both posteriorly to displace the rectum away from the implant, and then anteriorly to try and displace the bladder. So many of us in the US have converted from simple X-ray planning to getting a 3D CT simulation. And the benefit of this is that you're actually able to contour out the rectum, contour out the bladder, and know the volume of those structures that is getting a certain dose. So it can be helpful to use dilute contrast into the bladder. Some people use contrast into the rectum as well to better define those organs. And then the bladder is expanded with 120 cc's of sterile water, and that effectively pushes the bowel up and away from the implant. So what's showing on the screen is a CT scan in the axial view in the top left and coronal view in the bottom. And again, you'll see isodose lines. The blue is the 100% dose, so that's the 6 gray isodose line. And you can see the dose next to the tandem and the ovoids is much hotter, but it quickly does fall off. You get an appreciation on the lower slide here of this kind of pear-shaped distribution. And this is helpful because you're able to get dose up in the vaginal fornices, right in the cervix, and then cover any disease that may be extending up into the uterine cavity. So before CT, even just plain films was incredibly helpful in terms of assessing the quality of an implant. And just very briefly, the implant, you'll see I have it outlined and color-coded here. So we see the tandem is about 1/3 of the way between S1, S2, and the pubic symphysis. The tandem should be mid-positioned between the bladder and the sacrum. If you've placed marker seeds, you'll be able to see them on an X-ray, and you should make sure that your ovoids and the flange are right up against those seeds so that you can be sure that they're right up against the cervical os. The tandem should bisect the ovoids. You never want to see the ovoids completely in front of or completely behind your tandem. And then if you've used radiopaque contrast in your packing material, you'll see that the bladder and the rectum are packed away from the implant. You don't want to see the packing going above and above the ovoids or existing way down here where they're not going to really have much of an effect. So the ovoids should completely fill the vaginal fornices. The ovoid should be separated by about 0.5 to 1 cm. And this always depends on the implant, but the point is you don't want your ovoids to get stuck against the flange, which would mean they're not quite up in the vaginal fornices. And then again, the axis of the tandem should be central between the ovoids. So, as I said, in the longest history is using plain X-rays and defining the quality of implants based on 2-dimensional anatomy. And we have very well established definitions of proper placement. But in our effort to account for 3 dimensions and really knowing what structure is what dose is actually going to the rectum and the bladder, there's been a general trend to move to CT planning. And then in actually more recent years, there was a realization that, hey, CT gives you a great view of rectum and bladder, but you really can't see the cervix, or sorry, the tumor. So CT, you're really not able to determine what is tumor, what is not. You can kind of outline the uterus and the cervix, but you don't have an appreciation whatsoever for what is tumor, what is not. That requires MRI. Obviously, MRI is not available at every site, even in the US, and so materials being limited, that is often not being used. But when it is used, it is very helpful in outlining the tumor. So as I said, the 2D era had such a long experience, and it led to very well-defined definitions. We call these ICRU definitions. Basically, the dose is prescribed to point A, which is 2 cm superior and lateral to the os. This is supposed to represent the paracervical triangle where the uterine artery crosses the ureter. Point B is the pelvic side wall dose, meant to represent obturator nodes. And then we have bladder point, rectal point, and vaginal point. So, when you are using CT, instead of just documenting a dose to a point, you're able to document a dose to a volume. So the most commonly used is dose to 2 cc's. And what I have listed here is the dose constraints set forth by the American Brachytherapy Society, limiting the dose to 2 cc's of the rectum, sigmoid, and bladder. We haven't come up with a consensus to the 2 cc dose to the bowel because it's so incredibly variable. The hope is that with the fully filling, you can push the bowel out in a way. And one of the most helpful things is that the American Brachytherapy Society has designed this interactive worksheet, which is available on their website. And so most of us that do implants use that worksheet as a starting point, and then we take that back to our own clinic. That worksheet basically helps you calculate EQD2 for every patient. So the calculation is built into the worksheet. It's very helpful. The last point I'll make is that when we've converted from 2D to 3D and compared the ICRU definitions, the point definitions of bladder and rectum versus the maximum dose to 2 cc's of those organs, there was about a 2 centimeter difference in the ICRU bladder definition. And the reason for that is that depending on where that Foley balloon is, maybe it's not pulled down against the urethra, maybe just anatomical differences. But you can see here, if this is the ICRU point, yet this is the area closest to the, you're getting the highest dose, you're not going to adequately account for that if you're just looking at one single point dose. So I will end there. In summary, screening with pap smear has decreased mortality by 70% in the US. Very rarely are we able to achieve such a reduction in mortality with treatment techniques. So screening is important, and it's wonderful to hear about the screening efforts taking place here. Brachytherapy has an important role in treating nearly all stages of cervical cancer. Brachytherapy has been able to achieve improved local control and survival rates. ICRU definitions for target normal tissues do have the longest experience. However, the general trend is to move into the 3D era and use CT at the very least to contour out the normal structures and look at the dose going to the bowel and the bladder and the rectum. Thank you.